All right, here's what we're going to talk about today, and we'll go through all the liver pathology and then talk about biliary pathology after that. I feel like the liver's less fun than the biliary pathology, but we'll go through it all. It's important we look at the anatomy here, especially looking at like our right and left hepatic ducts become the common hepatic duct and the common bile duct. So this is where, we're going to see a lot of acute pathology, especially when we're talking about like gallstones, infections, malignancies. We'll talk about some of the vasculature here in a second, but those are kind of the important things we need to look at. And then we have like our sphincter of Oddi, which controls the bile flow into the duodenum, and some pancreatic juices as well. All right, so I know there's a lot of stuff on here, but I mean, the important thing to understand is, the liver, we use like Queneau's division of the liver into 8 segments, and it's really just correlates with the vasculature. So if we were going to do some surgical planning or removal, they kind of remove it in those different sections. There's nothing you need to memorize. Just understand that they kind of break down the liver. It's very vascular, so they break it down into its like vascular sections, and that's kind of how we look at it if we need to remove anything, doing any surgeries, or we're trying to isolate where some lesions are. And then we have like our common hepatic artery, but the important ones to remember are like our portal triad, because we're going to look at that later, especially when you guys are in EMED and doing ultrasounds. That's going to be something you guys will identify on your ultrasounds, and it's important when we're doing our evaluation, looking at the common bile duct. All right, and then just a refresher, our bile is composed of conjugated bile acids, cholesterol, phospholipids, proteins, and it's formed in the liver and the hepatocytes, and then it's stored in the gallbladder. And one of the things that, one of the important things it does is it has bilirubin, which is a breakdown of heme, and it's excreted in the bile. So this becomes important because when we have some sort of pathology, whether it's obstructive or malignancy, we tend to see this in the form of jaundice in our patients. And then obviously the liver is important in a lot of different processes in the body. Obviously glucose is central to that process. You got proteins that it makes, and it also has the metabolism of fat-soluble vitamins A, D, E, and K. And that's always something important to remember. I think I even saw a question on like my pantry about that, which you guys will love when you take the pants. It's like an entire textbook page for one question. And you're like, why did you need to write all of that information on there? So I just remember there was a question on one of those vitamins on it. It was a lot more complicated than just which vitamin, but it was a funny question. All right, so how do we image this, or what do we do for this? So the easiest, most common is obviously our ultrasound, and you can actually get decent visualization of the liver. It's not the best test, but it is the best test for like when you're looking at our gallbladder and our biliary tree. It's very simple, can be done at the bedside, and like I said, you guys will learn it during the EMED and the different scanning techniques we use. You'll mainly focus on the FAST exam, but you'll practice all of them, and you'll have to be tested on it too. We also, CT and MRIs are great studies for the liver, especially like CT with contrast is one of the more common ones you guys will use or see. And when we talk about all these liver things, all these liver pathologies and the cysts and the cancers, a lot of times you're not diagnosing these. You'll see them incidentally a lot of times on CT scans, especially when they go to the ER, because we don't follow them up and I tell them, hey, follow with your PCM. So you'll see a lot of these like cysts and all of these adenomas will commonly be seen in clinic, and you'll have to know like what your management is, whether it's something that could be malignant, whether it's something that needs a biopsy versus something that just needs routine follow-up. Most of them are just routine, like just observation. We don't do anything for them. We'll cover all those, but we do have like our nuclear medicine scans. Typically those are more of like our cancer scans. However, we do use some of them for some gallbladder pathology as well when we're worried about obstructions in certain areas. Then we have our angiographies, which just look at the blood supply. And then obviously biopsy, if we're concerned for any sort of malignancy and we're unsure, then we'll typically biopsy them. We'll talk about that as we go through these slides. So the liver is the most commonly injured solid organ in blunt trauma, and that's just because it takes up so much space in that area, and it's not completely protected by your ribs. So we do commonly see this in blunt trauma. It is the most commonly injured organ, but we don't do anything for it really. As long as it's not severe, patient stable. Typically, even with these, and we'll talk about it in block 3, liver lacerations and all the grading we use for them, most of them, we just observe them and monitor, and they usually heal on their own. So non-operative management is typically what we do. Now, it can also be injured in isolating penetrating wounds as well, since it takes up such a large area. You'll see that commonly too with penetrating trauma. And they might have some, abdominal distension, pain, tenderness. We always want to check a liver function test, just look at the intrinsic function of the liver, but typically we still don't do a lot for it. And then the one thing we do worry about is complications from those liver injuries. So we do usually admit them and do serial exams. We're looking for like biliary fistula, which is the most common sequela of hepatic trauma, and really it's just basically anywhere in your biliary tree can create a fistula or a connection to somewhere else, and then we worry about leaking bile into certain areas. And we also we can get pseudoaneurysms because it like I was saying, it's very vascular, so any of those vessels might get damaged and create an aneurysm. So those are things we need to worry about. And then rarely with trauma you can see pneumobilia. We typically see that which is air, and as you guys can see on the bottom CT scan there, it's not normal, right? There's a lot of dark spots in there where it's not supposed to be, so there's air throughout the biliary tree. And that's typically we worry about it with more in infections like gas-producing bacteria. And then we have bilomas, which is it's basically a bile abscess, so it's just small, sterile pockets of bile. And they typically are reabsorbed unless they're very large. Like on the picture there, you can see, that's pretty large on there. And if it gets that large, we treat it similar to an abscess. If it has if we're worried about major leaks, we typically do ERCP, which we'll talk a lot more about later when we're talking about common bile duct and choledocholidiasis. And then minor leaks, we just conservative management. They typically resolve on their own. Ultrasound is a great test for evaluation. It's not the best test for it, but it's really simple, easy at the bedside. We can do serial exams with it. So it is important that we are proficient with the point-of-care ultrasound. And then let's talk about our liver masses. So simple hepatic cyst, this is the most common one that we see. And these are usually, like I said, it'll be a patient that gets a CT scan or some sort of imaging for something else, whether it's an ultrasound or CT. And it'll be like an incidental finding. It's present in 18% of the population. So, I probably see it, I would say, on every shift if I'm doing a lot of belly CTs that day. So we just have them follow up with their primary care. We look whether it has those smooth, contoured walls, and that there's nothing malignant. Looking on the image, as you can see on the image on the bottom there, you can see it has a really clear wall on it, and then you have that anechoic lesion, and they're usually asymptomatic. We don't do anything for them. They don't require any treatment. If we're concerned that there's any sort of malignancy, we can do a biopsy on them as well. We can do some serologic testing. One of the things that you might see, not in the United States typically, like the echinococciosis, so that's like tapeworm, and it doesn't involve the liver, so sometimes in the right history setting, or somebody not, they were traveling, or they're not from the United States, is something to consider. You see it a lot more in other countries, we sometimes have our emergency medicine residents go down to Honduras, so they'll see this a lot in Honduras when they're out there working in the hospitals, and they will see this and treat it, but not something we commonly see in the United States. And then there's a cystadenoma, which it just has multiple septations, so that's that middle picture on the right. So as you can see, compared to that very clear anechoic smooth lesion, these ones aren't well defined. They'll have multiple septations, so that's concerning for malignancy. So sometimes those ones will be resected for treatment. Those top pictures look like something from aliens or something. Those are very large. All right, and then you can have polycystic liver disease, and it's just like polycystic kidney disease. You have multiple cysts. It's typically associated with polycystic kidney disease, with autosomal dominant polycystic kidney disease. You can also have just autosomal dominant polycystic liver disease as well. Not as common, but it definitely happens. And you know, most patients are asymptomatic, but it's progressive, so they have to be monitored, and we just look for, you know, how invasive it is, how many cysts are in the liver. Typically, we can, you know, some procedures we can do for it are like cyst fenestration, which is just draining them. But there's no real cure for this other than liver transplantation, and there's different types, like a type 3 is gonna require liver transplantation. It's incurable. So these are ones, I mean, you might see this. This might be incidentally found as well, since most patients are asymptomatic. So it's something to consider when you see multiple cysts on the kidneys in a patient, you know, an asymptomatic patient that's referred back to you. So it's important to just, you know, keep this in mind. If they're having symptoms, then we need to, you know, usually either they might get the fenestration or we might refer them to a specialist for further evaluation. And they're very vague symptoms, like, you know, fullness, early satiety, maybe some abdominal distension. And then the most common liver tumor is going to be your hepatic hemangioma. These ones are very common too. They can be, you know, you can have congenital vascular malformations with it. Usually asymptomatic as well. We find them incidentally, typically on a CT scan that we're running. The best test for it, or the most sensitive and specific, is going to be your MRI. And as you can see, the issue with these is they can be pretty large, so they can start to cause like compressive symptoms and other issues. But they do light up very well on like your T2 weighted imaging on the right side there. You can see it lit up pretty well. And you can also see it on the left image as well with the T1. But both of those are, you know, that's going to be your test of choice if you're worried about hepatic hemangioma. And then once again, most of these, they're asymptomatic. We just observe them. If they start to have compressive symptoms, like as you can see in that picture, that's pretty large, so it's likely causing some sort of compressive symptoms. Then we'll typically refer them, and it might be something that we need to operate on and remove it. Then hepatic adenoma. So what's important to remember for this one, so this is typically benign. It can be, you know, one of the issues with the other lesions are we worry about rupture and hemorrhage, which is a lot of times why we remove them, which we don't worry about with this one. So we typically don't have any rupture or hemorrhage with it. But what's important to consider with this one, this is going to be a patient that's usually like, you know, a childbearing age female, they're on oral contraceptives. And it's important to remember size differences. So if it's small, less than 3 centimeters, a lot of times we observe it. If they're on oral contraceptives, we typically want to discontinue those because it is associated with that. And a lot of times these will resolve on their own if we stop those oral contraceptives. This is typically benign, but sometimes looking at, you know, if you don't have like well circumscribed lesion, any concern for malignancy, they'll sometimes do a biopsy on them. And sometimes it can be hard to tell the difference between a hepatocellular carcinoma and a benign adenoma. But if they're having symptoms, then we can, you know, if it's over 5 centimeters, a lot of times we'll remove them, just because they can have compressive symptoms or anything larger than that. And if it's, you know, rapidly expanding, a lot of times we're worried about malignancy, so we'll remove it for that case and then send it to pathology to evaluate for malignancy. And then focal nodular hyperplasia. We typically see this in females, typically, you know, 20s to 40s. It's benign, so we don't really do anything for it. They typically resolve on their own, which is good. If we're concerned for any malignancy, obviously we do a biopsy on it, or they'll resect it depending on the size. Once again, if they have compressive symptoms or there's any sort of other symptoms with it, we'll tend to remove those, but typically they're managed non-op. We just observe them, serial imaging studies. And then hepatocellular carcinoma. So it says it's got the second highest mortality rate. I don't know if that's true today. Maybe like, you know, 5 years ago it might have been the second highest mortality rate. It is a very common cancer worldwide. more common in like Eastern Asia. So a lot of times associated with like the chronic Hep B and C infections, which we test for a lot of times in the United States. We have a better like blood product system as well for screening, so we're not infusing anybody with contaminated blood, which is why you don't see it as commonly anymore in the United States. You see it more frequently overseas, but it can also be associated with alcohol abuse, like non-alcoholic steatohepatitis. You got your aflatoxin, which is like a fungal metabolite that you can see if you don't, like it really in more third world countries where they don't have all the regulations on food, you'll sometimes see it there as well. And then what we like to do is stratify them on whether it's like high risk. So anybody with Hep B or Hep C, we typically get like an ultrasound every 6 months screening for this. And then they may get like the serum alpha fetoprotein as well, which can be, which is a tumor marker that we look at. It's also one that we look at when we're doing like our screening for the babies when they're in the fetus as well. But typically, like a CT or an MRI is a better test to diagnose this. And then, but ultrasound is a great screening test, and it's, like I said, simple, non-invasive. You can do it at the bedside, just looking for any sort of lesions. And then, we're going to do any biopsies for any concerning lesions we see. And then we can do surgical resection. Transplant is typically going to be our definitive treatment. They can do ablation as well. And then we have palliative options too, if it's, depending on how far along it is in the disease process. There's, a bunch of different grading criteria, like 0 through 5 for this. So depending on how far along they are or how bad the cancer is, a lot of times there may not be a lot we can do at that point. And then the liver commonly gets metastases, especially from like colorectal cancer, which is very common. So, we can see these metastases, and they're usually asymptomatic, which is the unfortunate problem. This is why a lot of times when we diagnose cancer in a patient, we'll do those like PET scans throughout the whole body, just looking for any sort of metastases. But colorectal cancer is commonly associated with liver metastases, so it is something we can consider, especially if they have any sort of colorectal cancer. And then we can do a surgical resection for them. It doesn't have, like, untreated, not a great survival rate, but even when we treat it, still a 5-year survival rate's not great, it's around 50%. And then they usually get recurrence of the symptoms as well after resection, so it's not a great prognosis for this. And then acute liver failure. So this is one that, we definitely see, even in the clinics. I know at Moreno, they had like a fulminant hepatic failure a couple days ago just from like a Hep A infection in a young, healthy, basic trained, or not basic trained, but what an AIT kid. So that was, it was kind of sad. But so this is just, basically it's a relationship with we see chronic liver failure a lot more frequently. But the acute liver failure typically presents with like your jaundice, you have your encephalopathy, coagulopathy. We call it fulminant hepatic failure when you have encephalopathy within 2 weeks of the onset of the jaundice, which is what happened to the kid that was at Moreno. And he needed, because you had that, all that coagulopathy, he ended up needing multiple units of blood. It didn't, I don't know what the ultimate outcome was, but it didn't look very good for him. Most commonly in the United States, we see this with Tylenol toxicity. So a lot of those overdose patients, unfortunately, a lot of them will require a liver transplant after, depending on the dose they took. But I definitely see it in the ER quite frequently. And it's very sad and unfortunate when they do, and a lot of times it's a younger patient. Like my last one was 16 years old, very sad. But we had and they might have actually gotten a liver transplant, I don't know. But we transferred them to a liver transplant center. And then there's multiple like manifestations of this. So typically, most of them have the jaundice with it, or all of them usually have the jaundice with it. But then we got to worry about whether they have any encephalopathy. I don't know, I can't say it today. And that'll be like, that's why we draw pneumonia on these patients. You can see all the other testing we do. We always want to look at like their coagulation profile, liver function, renal function. Once the liver starts to fail, it can decrease some of your like vascular flow to the kidneys. So you'll see kidney failure as well, and that's when we call it hepatorenal syndrome, which is very commonly seen with these acute liver failure patients as well, so it's important to monitor that. Then like it says on their toxicology screen, if we're unsure, sometimes the patient won't tell you what they took, which I've had that too, or they took a bunch of Tylenol and didn't want to tell anybody what had happened. So that's why we cast a broad net with these. So, and that's when we noted it when we did our tox screen, or it's really a Tylenol screen on it. And then a lot of times these patients will present septic, so it is important that we resuscitate them first. And then they can have ascites as well. With this, we see ascites a lot in chronic liver failure, which we'll talk about next. But these ones, yeah, we typically get everything on them. They'll get a chest X-ray. Once they're admitted, we'll get an MRI. We do the ammonia, just check them for any encephalopathy. And they can do a liver biopsy as well, just to confirm the diagnosis. So, like we were saying, what do we do for them? Most of it is resuscitation and monitoring, unfortunately, unless we're at a liver transplant center or they need a liver transplant, then we'll transfer them there. But like I said, they can have that renal failure, so they require a lot of work on these patients, and we trend their liver enzymes. We look at their INR and their coags, because that can be another intrinsic sign of liver disease. If they have a significant rise in their bilirubin, that's usually portends a poor outcome in them. And then they can do resections. You guys don't need to memorize your child Pew and your MELD scores. It's important just to remember that this is associated with liver failure. You guys will probably see this at your phase 2 on your rotations. They'll talk about MELD scores, especially when you're rounding with with the hospitalist or internal medicine when you're on those rotations. So it's just important to remember what you use those for. You can pull it up on MD Calc if there's you have any questions on it. All right, chronic liver disease. So we see this a lot more frequently, just because it has so many complications with chronic liver failure. So, and this is typically that, that alcoholic patient, they don't stop drinking, and then slowly they progress into liver failure and typically end-stage liver disease if they don't continue or if they don't discontinue the alcohol, which maybe they do, but obviously the ones I see haven't. So I guess I'm kind of biased because when they present, typically they still haven't stopped consuming alcohol when they end up in. Usually they'll present, most commonly the ascites gets really bad, and just because their belly is so engorged or distended, they'll typically present. And most of the time, we'll have to drain those. Or you'll have to do a paracentesis, typically, to help resolve that, and then we obviously do a fluid analysis as well. But one of the concerns of the complications is portal hypertension. As you see in the picture there, you have your that's complete medusa, but you can have jaundice, ascites, esophageal varices. Our concern is bleeding, since it does cause a significant coagulopathy. Bleeding is a pretty large issue with these patients, and that's what we worry about. And when they do present with an upper GI bleed, it's usually massive. It's not great. It usually has poor outcomes as well, but typically they require, a massive transfusion when they do present with this. There are ways we can help prevent it or help prevent the first bleed, which a lot of times we can do beta blockers before the first bleed, and that can help. Abstinence from alcohols, obviously a huge one, which a lot of people don't do. And then we do have procedures like our TIPS procedure. That's become a lot more common now. If we're concerned for encephalopathy, then we can give lactulose, and comes in a little cup. And they chronically are on lactulose. If they have an elevated ammonia in the ER, we'll start them on the lactulose, or we'll also start them on it just for preventative therapy too, depending on what stage their liver disease is. But it does reduce the ammonia production in the gut. It also comes in your guys' medical equipment sets. They're like little shot glasses almost, they look like. And it is fun to play jokes and put it in people's coffee or something. Not saying I ever did that, that'd be wrong, but yes, it is something that you'll see. And then, less commonly you can have Chiari syndrome, which is just hepatic vein thrombosis, and it causes an outflow obstruction. Typically a younger female patient, they'll have some right upper quadrant pain, hepatomegaly, maybe ascites. It can progress to, fulminant hepatic failure, but it typically doesn't. So the clinical course is usually benign. We just want to, make sure we monitor their liver enzyme levels and like serial liver enzymes until it normalizes. We'll get an ultrasound or CT on them as well. And then, they can receive anticoagulation. They might need a TIP procedure, but typically they're pretty benign. They don't require anything other than monitoring. All right, I'll give you guys a second to read this. This one's pretty easy. I do love how somebody put asbestos on there. That always makes me smile when I see that. Just randomly threw that on there. What do you guys think it is? Yeah, alcohol abuse. All right, this is the more fun stuff. The Hepato biliary tree in pathology is a lot more fun, and we see it, almost every day in the emergency room. Very common surgical procedure. And then there's our different nomenclature. So, like I said before, words have meanings, so this is how we tend to discuss them. And we'll get into all of that pathology. But what's nice is our first line studies can be an ultrasound on these, and we can do it at the bedside, very easy, quick. Sometimes, especially if they have like some right upper quadrant pain, or I suspect this immediately, even my initial evaluation, I'll show a little ultrasound machine with me when I'm doing the history, just like I can do it during my physical exam, and you can help kind of stratify what I think is going on with the patient. So it's a great study for this, very easy. But, we do have different measurements that we'll talk about here, and typically we'll look for any sort of like pericholecystic fluid, which if you look at that top right picture, you guys see how there's like, you see that gallbladder there and the anechoic portion, and you see that kind of discoloration around it. That's going to be your pericholecystic fluid. You can have your anterior wall is a little bit taken too, so anything over 3 millimeters. These are easy measurements. You use a couple clicks on your ultrasound and you can measure it. And most places will even, like I have on my hospital badge actually has, like our ultrasound director gave it to us, and it has all the measurements for what bedside tests you do, what studies, and what you're looking for. So, which usually you don't need, but some of the, like there are less common tests you're gonna do. And sometimes people are like, oh yeah, what was the measurement on that one? So, I would ask your facility if they have anything like that. It's a great resource to use. And then one of the other studies is the ERCP. This is very common. Typically, you'll have to refer them to the gastroenterologist, or they'll most likely be admitted to the hospital. The gastroenterologist will round on them, and they may do this study. And we'll talk about when we're going to use this and when we don't. But this is really when we have gallstones, that's usually easy. And if there's signs of cholecystitis, like the things we were just saying, like the anterior walls thickened, you have that pericholecystic fluid, patient sick, and we'll talk about some labs we do. But once that stone kind of moves down out of the biliary, out of the gallbladder and down into the common bile duct, we get obstructions there, and that's when we use our ERCP. So it'll be a better test for that, and we'll talk about that for which one. This is typically like if we're concerned with choledocholithiasis, this is the test of choice that we use. There are other ones we'll talk about, like MRCP next, but this one is both diagnostic and therapeutic, which is why we like to use this one. And then here's our MRCP. It's a, non-invasive is great. It just is not therapeutic like the ERCP. And it's not, some facilities it's not as common at. If you have a gastroenterologist, typically you're doing the ERCP. If not, that's when you have MRI, that's when they may be admitted to do the MRCP. And then if you do find a stone somewhere in like the common bile duct or further along, that's when you may have to like transfer them to a gastroenterologist that can do the ERCP. And obviously MRIs are more expensive, and this test is a little bit more expensive to people, more just because of the way you're looking at the contrast as it moves through there. So there's a time study, and it's typically for these ones they'll be, like we don't do them in the ER, we'll admit the patients for these. And then we have the HIDA scan as well. This is supposed to, this is the most sensitive and specific. Some facilities, once again, may not have this test as well, but this is another great one. It's a radionuclide scan. And basically, it colors the bile. And then you can watch the bile actually move down the common bile duct and then hopefully in the duodenum if they don't have any obstruction there. But this is another test we can use as well and to consider. All right, let's talk about gallstones. So cholelithiasis, that very common, see it all the time. The question we have to decide is whether it's symptomatic, asymptomatic, whether we're concerned for cholecystitis, but it does affect, like I said, 10 to 15% of the population. So we see it very frequently, almost daily. You guys remember they still teach that, or is it too offensive now, the like 5 Fs or whatever, the fat, female, 40, flatulent. I feel like I'm missing one there. Fertile, there it is, yep, fertile. Yep. And it can be more common in certain ethnic groups. I feel like it's common in everybody, we see it quite frequently. But really, you get typically a cholesterol stone that forms and it becomes supersaturated with cholesterol, and then you get bile stasis. Can also contribute to it, especially in pregnancy, so that's why we see this commonly in pregnancy as well. And then we won't talk about pigment gallstones here, but that's something that to consider as well if they have any sort of sickle cell disease, thalassemia, any of those other like congenital findings or hereditary findings. And typically the patient will know they have that. All right, so a lot of times you see this asymptomatically. Maybe one of you guys, when you're scanning each other, will have a stone in there randomly. That does happen. So when you guys are practicing on each other, you might find a stone. Typically, we don't do anything if they're asymptomatic. The issue is it can become obviously symptomatic if it somehow obstructs anywhere in that biliary tree, and that's when we start to get symptoms with it. But asymptomatic coli, we don't typically, prophylactically remove the gallbladder. It's the moral of the story. All right, what did we say gallstones were made of? Which one? What do we think? Yeah. So it's least likely from triglycerides. So obviously it's made of cholesterol, bilirubin, calcium plays a role in it as well. And then we can get chronic cholecystitis, which we typically call biliary colic, or we call it symptomatic cholelithiasis. So, and that's usually transient. They'll have right upper quadrant pain. It's intermittent, so it sometimes occurs after meals. They may have some nausea or vomiting, but it typically resolves. So a lot of times, not a lot of times, some of the times you'll have a patient that had asymptomatic coli and they'll present, they'll say, hey, they did tell me I had a gallstone once, but I've never had any issues. So you may see that as well. Typically, they don't look sick, they're not febrile, they're normal attentive, their labs are usually normal, physical exams typically benign unless they're having an acute episode. And they present, but typically they don't present when the acute episode. They'll have the pain, it'll wake them up, or it'll be after a meal, and then by the time they get there, they're like, oh, it resolved. So once again, super easy to throw an ultrasound probe on there and check for any gallstones. And so there's some the ultrasound on the left, obviously you can see the gallstone there, and then we have our other scans we can do as well. The key is we want to differentiate whether it's acute cholecystitis versus just a symptomatic cholelithiasis, and we do that from all those measurements I was talking about, like the anterior walls thickened, you have that pericholecystic fluid in there, you may have like your CBD measurement may be increased. But for these, if the diagnosis is anywhere in question or if it's intermediate risk, we can do an MRCP for it. We also always want to check the bilirubin level as well, because that can be elevated with any sort of obstruction we have, especially like when we're looking at anywhere further down, like the CBD. So typically when they're symptomatic, that's when we'll do a cholecystectomy. The good thing about this one, when it's chronic or it's biliary colic, we don't have to do it right now or immediately. So sometimes we'll do like a routine elective surgery, typically like in the next month, depending on the symptoms, which is nice, and especially if they're young and healthy, it's even better. But it's typically an outpatient procedure. We'll talk about acute cholecystitis, which is when we need to remove that gallbladder immediately, so that's when you actually have the gallbladder is inflamed, you got some sort of occlusion. It can lead to like ischemic necrosis or perforation. This is typically some sort of gallstone is obstructing the outlet, and it's causing these symptoms of engorgement, which can lead to perforation. They'll typically have a fever, some nausea, vomiting. They'll have some anorexia with it. This is when you should have like your Murphy sign on exam, or you might. And then they can have a mild leukocytosis. If we're worried about like a cholangitis or any sort of gangrenous cholecystitis, they'll typically have a lot higher of a white count. And then they can have some like transaminitis as well, which we'll talk about, which is more important that we're going to look at. So once again, ultrasound for all of these, it's very quick, easy. We can do it at the bedside. Depending on where you work at, some places will save the scans that you do at the bedside, some places won't, so that just depends on where you're at. You may have to order a formal ultrasound for these so that the surgeon can look at it and help identify that. And then what's important here is we need to decide whether we think there's any sort of obstruction in the common bile duct associated with this, because then that's going to usually have a worse outcome if we don't identify it, and the cholecystectomy doesn't improve all of the symptoms. And we'll talk about the different treatments we do for this. But when we see this patient initially, then we're going to make them NPO. And typically all of our belly pain patients, that's what we do when they arrive. We make them NPO. They'll try to sneak things in, but which happens. And then we usually do some sort of IV hydration, depending on how long the symptom of destruction has been going on. They might have had the anorexia. They might be a little bit malnourished, so we may have to resuscitate them. If we have like intractable vomiting and our medications aren't helping, we may put an NG tube in as well, but this is when we typically do the laparoscopic cholecystectomy. And there are, if they're, an elderly, multiple comorbidities, are not a great surgical patient, sometimes we can just do a percutaneous drain as well, so cholecystotomy. Sometimes they don't completely improve the symptoms. Sometimes they can recur. So we don't love to do that, but that is another procedure we can do, and then we can manage whatever comorbidities, like if they're very, uncontrolled, like the hypertension, not controlled, diabetes. Sometimes we'll do this until we can get all of those comorbidities under control, and they would be a better surgical candidate. All right. What do you guys think? Yeah, pretty easy. We just had on the left side. All right, so we can get an acalculous cholecystitis, and this is going to be more of your inpatient patients that are extremely sick and likely from some sort of biliary stasis leading to ischemia, but we don't find a stone with this. It is something we consider, especially patients on like TPN, especially on the burn units, we'll see this. And we can also see it after like major operations where they're hospitalized as well. The problem with this is a lot, complications are more common, like the gangrene, perforation, gallbladder empyema. So the mortality is pretty high, which is why we always want to consider this in our longer inpatient stays for our patients. All right, choledochal lithiasis. So this is, the gallstone starts, in the gallbladder, goes through the duct, and then it moves down your common bile duct, and you get some sort of obstruction along the way, and that's what we call choledochal lithiasis. And typically they'll be a little bit more sick. Sometimes it can be asymptomatic. Usually if they're presenting, it isn't. They would likely have some, that we see it down there, like Charcot's triad can be, an indication that they have cholangitis. And then we have like Reynolds Pentad, which we'll talk about when we talk about cholangitis here in a few moments. But typically they might have some sort of jaundice. I've typically seen jaundice with these. And the first place you see it is like the icterus and the eyes. So it's always something to consider, especially with the right upper quadrant pain patients. Make sure you're doing a good exam on them and checking that. Sometimes it can be very mild, but it is important to do a good physical exam. And then it can also lead to pancreatitis as well, because as you guys saw in the anatomy where that the common bile duct eventually leads into the pancreas, and the pancreatic duct and they all connect, and then they dump into the duodenum, so you can also end up with some pancreatitis as well. But we need to consider this with all of our, cholecystitis patients and try to determine whether we think there's a stone somewhere in the common bile duct. And we do that with our labs, really, and our bilirubin is the best individual test, which is why we always get like our CMP or our liver function test when we do these. And we always want to know the bilirubin level with these patients, because that can be an indication, hey, I think there's some sort of obstructive pathology further down, and we may need to do an ERCP. We may need to do a cholecystectomy, and then we may need to add the ERCP on it as well while we're doing the surgery, or we may just need to do an ERCP to treat this. And then our serum alk phos levels typically rise as well. You may have mild AST and ALT elevation, but typically your alk phos is associated with this. So once again, we do our bedside ultrasound, and we're looking for just any sort of CBD dilatation. If it's over a centimeter, great, that's a lot more specific. Typically, if it's over 5, then we'll start to get concerned that there may be some sort of stone there. And then if we do suspect this, then we need to send them for an ERCP, which is typically done by the gastroenterologist. And it can be diagnostic and therapeutic. So they can remove the stone, as they can evaluate for it with the contrast, and they can remove the stone, which is great. And then, if it's a facility where you don't have ERCP, you may have to do the MRCP. And the issue with choledocholitis is it can lead to cholangitis. And that's why we get concerned with this, because this can be pretty severe infection. And you guys remember all your like Grade Turner and colon signs? You sometimes see that with this if it's affecting like your pancreas as well. So these patients get really sick. They're typically febrile. We don't want to remove the gallbladder or do the ERCP immediately with this. We want to treat the infection first. So we'll give them typically systemic, some sort of like broad antibiotics during the initial attack until we can improve that, and then we send them for the laparoscopic cholecystectomy. And then here's treatment algorithm. And the big takeaways on this, if they have any of these features that they're high risk, then we need to be concerned that it might be a choledocholithiasis and not just acute cholecystitis. Like I said, if they're CBDs, over 6 millimeters, their billy's elevated, and their billy's typically it'll be quite elevated with this, typically a lot higher than 1.7, usually like 2 to 4. If it's cholangitis, it'll be a lot higher. Elderly, we get more concerned with this. And then any visible stone on ultrasound as well, we place them into a high risk category. And that's when we need to look at doing the ERCP versus just cholecystectomy.
Sir, do we get pancreatic labs on these
Yep.
folks as well?
Yeah, we'll get the lactose on. And we'll talk about that in the next lecture. And then cholangitis is a bacterial infection of the biliary ducts. This is, pretty bad. This is when you're going to see your Charcot's triad. You may see your Reynolds pentad. And it says the complete triad is present in only 70% of cases. That's pretty high in medicine. Like 70%, that's a pretty big number if you see that. Yeah, so you do see this quite commonly. And then this is an obstruction leading to an infection. So this is when, obviously, we're going to need to resuscitate them. They're going to need like broad spectrum antibiotics. A lot of times they'll present in sepsis, especially if they're elderly. So resuscitate, and then we need to antibiotics and treat them. Our lab findings, they usually have a significant leukocytosis. Their billy will be typically 6 to 8, 10. And then they'll have elevated alk phos levels as well. We typically cover for broad, like gram-negatives, anaerobes. We cover for all those. The abdominal ultrasound, again, is a great initial study we can do, and then we can look at doing the ERCP. But the first thing we need to do is resuscitate these patients, treat the infection. All right, I'll give you guys a second to read this. So what do we think this one is? Acute cholecystitis, everybody agree on that? All right, what if we had this patient and they had like a Billy of 6 and some jaundice? What would be the test you guys would want to do for this after your ultrasound? What would be your next best test? What was that? CRCP? Yeah, good. Yeah, so cholangitis, most of them, we control it with antibiotics, and then we follow it up with the ERCP. If, you know, we don't see any improvement after antibiotics, then we may have to look at different types of drainage or other therapies. They may still go for the ERCP because that might be the limiting factor on why we're not improving this infection. But these can be very complicated patients when we're managing them. And yeah, we can do like the ciproflagyl, very common medication we use. We also use Hepato as well, which is called Zosyn, so that's probably more, might be more common now, it's a little bit more expensive. But instead of having to give 2 different medications, it's one combined medication, so it can make it easier. But it's also going to be region specific, so you look at like your resistance patterns, and all your facilities will have them. It's easy just to ask somebody what they typically use on that surgery specialty. And then, you guys want to take a 10-minute break? Cool, take a 10-minute break. We're talking about the actual procedure now, the cholecystectomy. And we talked about the indications for that already. So we have, you know, all the conditions we just covered. And then we make a decision whether it's open versus laparoscopic, just like we talked about with the like appendicitis as well. Most of these are done laparoscopically now. And we typically, you know, we have to insufflate the belly with CO2, and then we place our ports in, and then we'll get into the procedure on the next slide. You can also do an open procedure as well with Coger's incision. So, I mean, won't get too in the weeds in the procedure. The important part to remember is, like, we have a critical view of safety that we like to refer to when we're doing this. And that just helps us identify everything that we're going to need to dissect when we're in there. And we have to, you know, the things we worry about are all those other structures in there, especially like our CBD. We've got all of our vasculature in there. So we want to make sure we're not injuring any of those while we're doing the procedure. Which is why a lot of times after we remove the gallbladder or dissect it out of there, we want to do like an intraoperative cholangiogram. So we'll put some contrast into the cystic duct to make sure we didn't have any injury to the CBD. And we're just looking for like any contrast, extravasation on there. And then obviously, you have all your complications with every procedure, like bleeding, injury, other structures, infection. For this one, like we do have, you know, we can see, you know, a bile leak with it. It can have those retaining stones, which we'll typically see on our intraoperative cholangiogram. When we put that contrast in there, we may see an obstruction still. And at that point, we might have to go to like an ERCP, or we have to get the gastroenterologist there for the ERCP. And then obviously you can have incisional hernias with any sort of procedure. And then if the patient isn't a good candidate, like we'd said, for surgery, like, you know, elderly, multiple comorbidities, a bunch of comorbidities aren't controlled, we may have to just do a percutaneous drain on them, which is relatively simple, can be done at the bedside, typically under ultrasound guidance. And we just place a tube in there, decompress the gallbladder. They should show improvement 24 to 48 hours later. If they don't, that's when we have to inject it with contrast, and we want to make sure it's actually in the gallbladder, because sometimes we may not be in the right location, or it could have migrated out of that location. We typically leave it in place until they're fully recovered, but this is another option we can do if they're not a great candidate for a cholecystectomy. and follow-up for these. So typically, with every patient, we have an NPO, then we advance their diet while they're in the hospital so they can tolerate solids. We'll trend their leukocytosis if it was elevated. They had like a cholangitis, or it's usually going to be elevated acute cholecystitis as well. We want to make sure we're looking at their electrolytes. We're giving them IV antibiotics until they're afebrile and leukocytosis improved. They'll will need some sort of prophylaxis for DVT, which typically Lovenox is a very common one. Anybody who's in the hospital, we always worry about like atelectasis, and so we'll give them a spirometer. So we'll have them take deep breaths every hour, a couple times every hour. The nurses will come in and require them to do it. We obviously want to make sure we have good pain control. And typically, once that criteria is met, we send them home. A lot of them will leave, within 24 hours from the hospital, especially if it was uncomplicated. And then we're just checking, evaluating their incisions, looking for any signs of infection, make sure it's healing appropriately, and they can return to normal activity, typically in 6 to 8 weeks. And there's everything we covered today. I know it was a lot. What questions you guys have?
Regarding the liver cancers, I know hepatocellular carcinoma is associated with a history of alcoholism, but do the other types of cancer typically just occur spontaneously, or are they associated with a history?
Some of them can be spontaneous, yes. A lot of them are associated with liver or some sort of hepatitis infection, or they're metastases from somewhere else, are most commonly the ones we see. What other questions? Did you guys see that plane crash yesterday? Sad. Cool. All right, I'll hang out for a few minutes. If you have any questions, let me know.